Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is for a patient who attended with really blocked earwax in both ears. They had a very sticky and soft fudge type consistency of wax. And we're just going to start off with the right ear. And you can see just laterally here, there's a little tail that extends from the plug of wax with a few matted hairs. And I initially used, this is a standard Zollner suction probe. So this suction probe is the most commonly used suction probe for earwax removal. The length of this probe is 8 centimetres from the tip to the hand, where the suction steel starts at the handle, and the handle's an additional, I'd say 3 centimetres possibly. And around 3 centimetres from the tip of this suction probe, there's a bend, an arc, a 30-degree angulation. And that 30-degree angulation corresponds and correlates to the average inclination of the ear canal. So everyone's ear canals, there's 2 bends, and also the outer part of the ear canal, the outer third, when you look into the ear, there's an incline. It's almost like you're going up a hill. It goes up by about 30 degrees. So because of the consistency of this wax, although I was trying to pull it, the ear was playing tug of war with me, and it wasn't releasing this plug of wax and matted hair. So I decided to use some forceps just to get some purchase, and you can see there's a few hairs that have been gripped by the forceps, but although this plug, the tail, I'm almost stretching it as opposed to extracting and removing it. I'm just stretching it at the moment, but I did get a little bit out there. And if you continue watching, you'll see why this plug was a bit difficult to remove. And that's because the plug of wax skin was lodged in the patient's anterior recess. So about 0.5 centimetre away from the eardrum, there's a natural narrowing of the ear canal, and then the ear canal widens back out again. And that creates a little recess or trench, if you like. Typically 2. You get one at the front part of the ear canal near the eardrum. So in the case of the right ear, on the right-hand side, very close to the eardrum, there's a hidden cave there. And also, we call that the anterior, so the front part, anterior recess. And then there's also a trench at the base of the ear canal near the eardrum, and we call that the inferior recess. And you'll see that in a moment. And again, you can see I'm really wriggling this plug, and you can see if you look deeper in the ear, it extends all the way towards the eardrum. Now we can just about see the back part of the ear canal here. And these little wriggle movements are designed to detach the wax and skin from the ear canal. So we've got a fair sized plug there. So this wax there, that remaining wax, is in the anterior recess. We can see the back part of the ear canal. And immediately I just put some olive oil in the ear to soften this, because I know it's trapped, I know it's lodged. So I thought, let's just put the drops in straight away. And at this stage, the drops are still inside the patient's ear. I didn't drain it. So I had the patient tilt their head. So this is the patient's right ear. So they were positioned in such a way that their left ear was facing towards the ground. So the head was tilted towards the left shoulder, which meant that the right ear was facing more towards the ceiling. And that allows the drops to remain in the ear without naturally draining out. So for me to perform the procedure, I'm actually off my medical stool and I'm standing up. So I'm looking down into the ear, and this ear is really, really narrow, so we have to be really careful. There's not much room for manoeuvre here, and we want to avoid touching the canal here. So the inner 2/3 of the ear canal, if you've been watching my videos, you should be well aware that it's very, very sensitive. There's a very thin layer of skin, less than 0.1 millimetres in thickness, directly lining and coating the canal wall, which makes the bony part really, really sensitive. And you can see I've just managed to manipulate that out of the anterior recess, so it's no longer lodged. I've mobilised this plug and I've managed to remove it. The outer third of the ear canal is cartilaginous, so we can put a bit more pressure there. And that's because the skin's a lot thicker. It's about 1 millimetre in thickness. There's a bit of fatty tissue there, a bit of muscle. So we can manipulate the outer third of the ear canal much more safely than the inner 2/3. Now, the patient's hearing's restored, they're hearing brilliantly, but you can see there's a bit of mushy, wet, dry, bit of wet, sticky wax around the edge. I'm just going to see if I can, without endangering the patient and causing them any discomfort, I'm just going to hover over this and see how much I can get out. If I'm worried that I'm going to cause trauma or I'm going to graze the canal wall or potentially perforate the eardrum, we stop straight away because the symptoms are alleviated. This wax, believe it or not, will naturally migrate on its own accord. Over time, the skin that lines the eardrum, as it dies and sheds, it moves sideways. The best way to kind of visualize that, if you're stood at a pond and you've got a pebble and you drop the pebble in the middle of the pond, you'll have the ripple effect. So imagine the pond being the eardrum, and imagine that pebble, when you drop it in the middle of the eardrum, the ripples being the dead skin. So as the skin dies, it sheds and it ripples away from the centre of the eardrum. Then it goes onto the ear canal and slowly it migrates out of the ear. The rate of migration of the dead skin, it varies from individual to individual, of course, but an average, or range, should I say, is about 1.5 millimetres to 3 millimetres a month. So if we average out the ear canal to be 3 centimetres, it's slightly less than that, but if we average it to be 3 centimetres, it's actually 2.6 on average in adults. It can approximately take 10 months at a rate of 3 millimetres for that skin to migrate. On the slower range, if your skin migrates at a rate of 1.5 millimetres a month, you're looking at 20 months, so just over a year and a half. Again, just I tilted the patient's head a bit further to the left so I can see the roof of the ear canal. This is a bit more stubborn, so I hovered over it. I got a bit out, but I left the rest because it wasn't... The only way I'm going to manoeuvre that is by applying some pressure on the bony part, which I don't want to do. So the eardrum's more or less fully visible. There's just a patch of bit of dead skin, this is. And you can see the bend on the suction probe. You can see that bend correlates with the bend of the ear canal. And I artificially created that bend myself on the suction tip. So I bent it. So when I inserted the ear, it avoids touching that bony part. And I just managed to get a bit more off the eardrum there. But I'm really happy with that. The whole eardrum's visible. There's a bit of sticky stuff, wax, coating the canal wall, so it's not occluding the ear, which is fine. We're going to leave that because that will be uncomfortable for the patient, and it's not going to, as I said, improve their symptoms by trying to remove it. This is the patient's left ear. So this is less blocked, far less blocked, but there's still quite a substantial amount of wax in there. And because of the right ear, and I had to put the drops in, and it was the best thing for the patient, I put the drops in immediately in the left side. And you can see you got that plug out. Now that plug was far more easier to remove because it didn't extend all the way to the eardrum. It wasn't lodged in the anterior recess. So the blockage is actually gone now. And what I'm just doing, because it's the cartilaginous portion, the outer third, which is semi-sensitive, semi-flexible, it's not as rigid and sturdy and as sensitive as the bony part, I'm just hovering the suction probe over the canal wall because there's a bit of dead skin here, you can see. I'm just still trying to be gentle. I don't want to poke and prod against the canal wall. Once more, the symptoms are alleviated. The eardrum's clear. There's no occlusion. So an occlusion is an obstruction, and that's when wax can affect your hearing. We all have wax, believe it or not, different quantities. If you've had your ears examined and someone told you haven't got wax, that's because the wax can form a really, really thin layer that coats the ear canal, and it's almost invisible to the naked eye. But wax is a preventative secretion by the ear to inhibit possible ear infections because the acidity helps to inhibit bacterial and fungal growth. The acidity in earwax, believe it or not, also acts and serves as an insect repellent. Because wax is quite oily and greasy, it's a natural moisturiser. We don't want that skin to dry up and crack in the ear because it can cause itchiness. So wax actually helps to moisturise the skin that lines the ear canal. And wax has the unique property of being sticky. So any foreign particles, dust, pollen, dirt that enter the ear, it will hopefully stick to the wax. And as the wax naturally migrates out of the ear alongside the skin, the wax expels any debris in the ear. So it's a self-cleansing properties earwax has, and anti-infection microbial properties also. There's a bit there on the back part of the ear canal. Again, I just hovered over with the fine end suction probe. Well, I hope you enjoyed that video, guys, and you all had a great weekend. In the UK, it's Mother's Day, so I'm wishing everyone a happy Mother's Day. And last but not least, remember to be nice and be kind. Thank you. Bye.